But there's also a flip side to it that I've seen. Sometimes clinicians may jump the gun and take the quote-unquote one-size-fits-all or the Band-Aid approach to pain management, meaning they may try to quickly provide a prescription for a patient which perhaps may help in the short or the immediate term, but may not address the underlying issue. And worse yet, it may even exacerbate the issues such as causing dependence and addiction, etc., especially when it comes to medications such as opioids or the benzodiazepines and some of the other addictive substances. You're listening to Pediatric Pain Focus, episode number 45, and we're talking about the 5 most common mistakes healthcare professionals make regarding pediatric pain. So, stay tuned.
Pediatric Pain Focus.
You're listening to Pediatric Pain Focus, brought to you by Proactive Pain Solutions. Pediatric Pain Focus highlights pediatric pain information and provides tools and resources for all healthcare professionals taking care of children dealing with pain. Here's your host, Dr. Anjana Kundu.
Hello there, folks. Thank you for tuning into Pediatric Pain Focus. I'm your host, Dr. Anjana Kundu. How are you doing? Well, it's been one hella week for all of us here in US. Though I'm sure, unless you were living under a rock, the entire world heard and saw the craziness that erupted in our capital last week. Just as we had thought, 2020 is finally over, and hopefully with that, the worst of it. But 2021 said, not so fast. And as the comedian Stephen Colbert says, 2021 says, hold my year. No one can refute that what happened last week in the U.S. Capitol was dangerous on so many levels and in so many ways. It was totally uncalled for and a really poor display of how to handle disagreements. And that too by the most powerful, the global superpower, the powerhouse of the world, to whom everyone turns when they're looking for an example and the standards in appropriate conduct. We certainly did not come through last week. We sure hope that the worst is behind us and that we as a nation can now move forward to make amends and heal this wound, both internally and externally. And speaking of examples and standards, pain care of children definitely suffers from inadequate standards of care, as is evident from the rising incidence and prevalence, but it continues to lack the appropriate training. I know, quite the switch there, right? Okay, maybe they're not directly related, but certainly talking about what happened in our capital, in our country last week is certainly painful. And clearly, I'm not here just to dissect that, and that's not why you're tuning in. So we turn to the issue at hand, which is pediatric pain, right? So when we have this increased incidence and prevalence of pediatric pain and poor training or inadequate training, then the outcome is that most healthcare professionals are faced with pain issues that they are not necessarily equipped to deal with adequately. They don't have the tools, they don't have the skills to manage them properly anyway. And recently someone asked me, what might be some of the most common mistakes that I have seen over my 20 years or continue to see amongst healthcare professionals when it comes to children's pain? So that triggered me to be here today talking to you about the most common and the most nefarious of those mistakes so that you may learn from those and perhaps avoid them or at least know how to handle them appropriately. So here they go. Mistake number 1 is that pain is often thought of a symptom rather than a disease process in itself. Now, pain is still primarily thought of as a symptom of surgery, illness, injury, or maybe another disease rather than the fact that it can be an independent diagnosis or a disease process in itself, especially when we talk about chronic pain or the neuropathic pain or conditions like primary headaches or abdominal pain. In cases of acute onset of pain, this possibly may be true, that it is a symptom of something else, some underlying condition. But still, even in those situations, that's not always the case. It is well established that pain after amputation, nerve injury, or what we call the neuropathic pain, and even after some of those surgeries, such as the inguinal hernia or big thoracic or chest surgeries, mastectomies for adults, the pain may be acute and causal in onset, that we know what caused it or there's a direct correlation, but its characteristics are completely different than what we know about typical acute pain. We know that acute pain can be protective and that it runs a very defined course and it resolves with the resolution of the injury or the illness, and typically in a predictable manner, in a manner of days to weeks, and typically with the use of maybe short-term interventions like medications such as opioids, anti-inflammatories, or nerve blocks, or even some multimodal analgesics, a combination of all those. And perhaps those might be the only interventions or things that we need to do for the acute pain, typical acute pain. Whereas when we think about pain like neuropathic pain or after amputation and such, that pain, even though it presents with a known cause, a known injury, and in a predictable manner like the acute pain, its nature, its duration, its prognosis, pathogenesis, and therefore the treatment approaches to manage this pain is completely different. For example, using opioids for neuropathic pain may give temporary relief, but in the long run, they are ineffective and also inappropriate. They may themselves cause some of the issues. So what's the bottom line for this? Not all pain is created equal, even if on the surface it may seem like it. And to manage pain appropriately, it is imperative to understand the underlying etiology and to address those etiologies using the correct therapeutic interventions and options. Enough said. Now talking about mistake number 2. Not prioritizing the treatment of pain in favor of quote-unquote more urgent healthcare issues. Too often, pain gets pushed to the back burner in the name of more urgent or more important health concerns. Whether they're justified or not is a whole different issue. Look, I'm not saying that we need to prioritize pain over life-threatening situations or the ABCs in healthcare. Nor am I saying that we don't need to treat infection, inflammation, or stabilize the fracture, etc., which may be leading to the pain. Of course we need to do that. But what we don't need is ignoring the pain entirely when it coexists with other issues. We know from research that there are detrimental physiological impacts of poorly treated or untreated pain, including things like high catabolic states, delayed wound healing, direct impact on the cardiopulmonary volumes and resistance, and direct immune suppression. And not to mention the suffering or the mental and emotional impact it has on the patient itself, as well as their caregivers. Pain is amongst the top reasons for delayed discharge or admission to hospitals and the most important determinant of quality of life. How you address your patient's pain will determine their perception of the quality of the care they've received in the hospital or in your clinic or from you. And if you are being honest, your ability to address your patient's pain directly impacts the doctor-patient relationship and their trust in you and the healthcare. Pain, whether it's acute or chronic, requires prompt attention, prompt attention does not equate immediate medication administration. What it involves is proper assessment of the intensity, the impact, the causative factors, and the factors that may be influencing the pain experience itself, which, of course, in turn will guide the appropriate treatment plan as well. And speaking of chronic pain specifically, it is a debilitating condition that requires prompt access to care for treatment, at least for the treatment to be effective anyway. Wait times of care often exceed the benchmark recommendations that societies like the IASP makes, with significant and potential consequences for the patient's health outcomes. The wait times to get adequate care for children can be as long as 6 to 12 months. Now think about that. What does that do to a child's mental health? Well, what does that do to a parent who's watching their child suffer? Research suggests that on an average, a pediatric pain patient has been evaluated by up to 13 other specialists prior to they finally visiting a pediatric pain specialist who can actually give them some respite. So this is an untenable situation. When we consider this in the acute settings, we know it delays their healing, it delays their discharge, it causes more burden on the healthcare system, not to mention the deleterious effects on the patient and their caregivers and your relationship with them. On the other hand, the benefit or the upshot of timely attention are manifold. Not only will it facilitate timely healing, improve the quality of the life of your patients, but also your own quality of life. When you have a better relationship, you get more satisfaction from the work you do. You're regarded by your institution and your colleagues in a better light. It also improves the doctor-patient relationship. It minimizes short-term and long-term deleterious effects. It prevents pain from becoming chronic or refractory to treat. So, next time, when your patient has pain issues along with their other healthcare concerns that you're primarily treating, keep that on the forefront as well. Consider what kind of impact it may be having on your ability to treat that healthcare condition if you address their pain as well. And listen, this doesn't mean you have to address their or treat their pain by yourself. You can call in an expert, but make this a priority is all I'm saying here. All right, moving on. Mistake number 3, focusing on the short-term gain over long-term benefits or fixes of the problem. What do I mean by that? So we just talked about how pain may not get the attention and it may be placed on the back burner. But there's also a flip side to it that I've seen. Sometimes clinicians may jump the gun and take the quote-unquote one-size-fits-all or the Band-Aid approach to pain management. Meaning they may try to quickly provide a prescription for a patient which perhaps may help in the short or the immediate term, but may not address the underlying issue. And worse yet, it may even exacerbate the issues such as causing dependence and addiction, etc., especially when it comes to medications such as opioids or the benzodiazepines and some of the other addictive substances. And this type of behavior or response from a healthcare professional may be a result of several factors. Number 1, we know that majority of clinicians do not receive adequate training in even the basic pain management strategies. We know there is a glaring lack of education and training in pediatric pain medicine, with only a handful of training programs, whether they're accredited or otherwise, but there are just very few programs that truly provide adequate pediatric pain medicine training. Then there is an obvious lack of curricula in medical schools or even during residency training related to pain medicine, let alone that being specific to pediatric pain. There's just very minimal pain-related training that is happening in medical schools or the residency training programs. As a matter of fact, the veterinarians get more hours of pain training than do medical students in North America. And I can tell you, recently had an encounter with our veterinarian for our kitten who underwent an abdominal surgery. I was so impressed by how they handled their pain management. The pain regimen that this little kitten came home included not only just the administration of a long-acting analgesic during the surgery that lasted for up to 24 hours, but we were given oral dosages of anti-inflammatories as well as gabapentin after the surgery for up to 10 days when we were going to go back and have the sutures removed for our kitten. And what was amazing was how clear they were both in terms of their written instructions as well as the verbal instructions that were given with us. Check that we understand how to give the medications, how much the dosage should be, how it should be stored, and even though this wasn't even a controlled substance. But I digress. Basically, my point is we need to educate our clinicians better, both in terms of how to evaluate, assess, and manage the pain, but also what they need to do to effectively disseminate that information to their patients and families. Another factor that may be contributing here to this focusing on short-term gains is the implementation of regulatory guidelines by agencies like the JCO or the CMS that are imposed on institutions without simultaneous guidelines for adequate training of healthcare professionals when it comes to pain management. Now, healthcare professionals are expected to assess and treat immediately the pain, mostly based on pain scores, which is a unidimensional measure of pain. As we know, it's a multifaceted phenomena. So, the healthcare professionals feel obligated to quickly act and administer medications so that they can document that they are following these guidelines and these requirements. Contributing factor number 3 is also the changing landscape of healthcare, in that there is reduced time for clinical visits and reduced reimbursement. Moreover, the reimbursements are being directed more towards the intervention and prescriptions rather than a thorough evaluation of multifactorial issues and appropriately addressing them. And this is in particular more relevant to evaluation of or management of complex conditions such as pain. So what's the end result of all these conditions and contributing factors? Clinicians take the short-term gains route so that they can move the patients quickly through the clinic or the hospital, or adopt the stopgap measure till they can send this patient to someone else to manage their long-term or more complex issues. That, of course, isn't as simple and straightforward as it sounds, meaning there are very few specifically trained pediatric pain specialists. So now the patient not only has the unmanaged pain, which may have become chronic and or refractory, plus they also have additional problems like addiction, dependence, and a long wait, and therefore maybe the mental health issues that also compound their pain issues. And this happens because most of the specialized centers or trained specialists for managing chronic and complex pain in particular, and especially those that offer those multidisciplinary approaches to this multifaceted problem, they mostly reside in larger urban academic centers at the moment. So enough about that. Moving right along. The common mistake number 4 is when healthcare professionals focus on normal tests rather than the patient themselves, or they may lose sight of the issues in presence of difficult, overbearing, or in quotes, demanding parents or caregivers. The belief that pain is a symptom of something else may result in the assumption by a clinician that if a test comes back normal or there's lack of any physical evidence or injury or disease, that negates the possibility of the patient having, in quotes, real pain. Worse yet, they may present that information to their patient as such, leaving that patient or their family with a sense of not being believed by their physician or the clinician as it relates to their pain. We all know that diagnostic tests will answer the particular question you ask, but for pain patients, asking the right question is often more elusive. More often than not, especially for chronic pain, the obvious etiology assessed using currently available diagnostic tests is often lacking. The fact is, the quality of questions you ask will determine the quality of answer you get. Now, another factor that may come into play here is how the parent or the caregiver's personality is and what is their level of involvement in their child's care or their presentation during this visit. Parents that may speak for the child or may share their own fears, worries, opinions, or ask more questions, ask for more investigations, they may be perceived by some of the clinicians as quote-unquote difficult patients or parents. You know what I'm referring to, right? The parents that may advocate for their child aggressively or come in with lots of records and notes or their own pain complaints, etc. Those are the ones I'm talking about. Now, granted, not all of their opinions, notes, etc. are applicable to your patient in your assessment and in your opinion, but remember, pain is a multifactorial condition. It is impacted by the biopsychosocial and cultural factors in your patient's life. Now, how you address the non-biological issues is equally, if not more important, for these patients and their families. Just as you feel that their opinions, concerns, and worries are not necessarily relevant to the reality of your patient's conditions, these parents or caregivers may have the same degree of conviction otherwise. Therefore, taking the time to explain the test results, their significance, the next steps, as well as acknowledging and addressing the parents or caregivers' concerns and questions can give them a lot of hope. It can give them confidence that their concerns aren't just brushed aside and that their child's condition is not being minimized and that you're not ignoring it. Last but not the least is common mistake number 5, which is underestimation of the impact of pain on patients, families, healthcare systems, and even on the society. Pain, especially chronic pain, affects physical and mental and social functioning of the affected person, as well as of those that are around them. It impairs the quality of life, their school attendance, their mood, their sleep, social relationships, and their productivity, whether it's as a student or as a member of the family, or their sports, or any other activities. It often results in feelings of sadness, anxiety, fear, irritability, helplessness, hopelessness, even major depression and anxiety disorders. These all can result merely from their persistent or chronic or unaddressed or untreated pain. And these effects are not just limited to the patient, but also those around them also get impacted adversely. Parents and families may disagree on their belief around the pain or on the treatment approaches, and they may experience discord or dysfunction within their family unit. We've seen parents often may have disagreements. One parent may think that the other one is coddling or babying that child with pain too much. They may be experiencing financial strains and disruptions because of the child's pain condition, because the parent may or may not be able to work because they're taking care of that child. Or the healthcare costs are too much. They may or may not be covered by their healthcare insurance. Now, there may also be sibling rivalry or resentment by other siblings because the child with pain may be getting more attention. They may not be given the same degree of tasks and chores in the house. The expectations from that child may be more. They may be getting more accommodations and more leeway with things that the other siblings aren't. So these may cause rift between the children themselves. Not only do they cause the sibling rivalry or rift, but it may even result in illness and behavioral issues from other children, because they may feel like that's the only way they seek attention. They can get attention of their parents is if they assume a sick role themselves. Not only that, the parents themselves, majority of parents of pediatric pain patients report feeling helpless about the understanding for their child's pain condition or their ability to effectively help their child with their pain or to manage even their relationship and their other children's needs. They report feeling lack of support and information to feel empowered in order to help their child or their family. This may cause mental health issues for the parent themselves. Pain also imposes a significant financial burden on the affected patient and families, and I referred to it just a little bit ago briefly. This could be related to the doctor's visit. It could be due to loss or interruption of their employment. And this financial burden is not just limited to the family. It may actually extend to the employers. For older children, it could be their own employers, but definitely their parents' employers. The parents may have often missed a lot of work days due to caring for their child, taking their children for their healthcare visits. They may be frequently taking the family medical leave. All those issues result in burdens on their employers, whether it's financial or otherwise. Now, the pain may also have financial impact on communities and the society as a whole. Research shows that children with chronic pain have higher rates of dropout from school. So they are lesser educated, they don't hold jobs as well in future, or they're not as employable. These children also grow up to become adults with chronic pain, mental health disorders, and disabilities, which again results in decline in the workforce or less productivity and less contribution to the society, to the economy. When we look at some of the ongoing costs, pain results in delayed discharge or the increased length of stay. It also results in frequent healthcare visits, whether they're outpatient, ER, urgent care, as well as more admissions related to pain control, pain issues. It results in poor satisfaction scores. It results in poor reimbursement because now the satisfaction scores and the outcomes are also being tied to reimbursement. Not to mention that it also impacts the reputation of the institution and may impact the referral income. And looking at some of the estimated costs of healthcare expenditure related to children's pain, there are very few studies, but even amongst those, it is estimated that there is an annual cost of about $20 billion related to pediatric pain care. Whereas the overall expenditure related to pain, adults and pediatrics combined, is estimated to be about $635 billion annually, and this is according to the Institute of Medicine report. So you see how deep the impact of some of these common mistakes can be. And I call them the most nefarious ones because they have the most significant and most widespread impact on not just the understanding, assessing, and management of the pain. And not only that, these mistakes not just impact the patient and the families, but they have equally undesirable impact and outcomes for the healthcare professionals themselves, as well as even beyond for the society and the community. And as we say, the first step to addressing a problem is to identifying it, to acknowledging it. Now, this episode may not solve the problem of inadequate training, although our programs like our Proactive Pain Solution Physician Academy or our free Pediatric Pain Management Masterclass that's coming up this weekend, those will do that. They will provide you the necessary basic or even advanced information around pediatric pain. So make sure that you take advantage of these programs that are available. But this episode is not to just advertise that. It is, however, to highlight and for me to hope that through this episode, I can motivate you to think and reconsider your own filters about pediatric pain, around pediatric pain management, and about how you are going to approach the pain complaints of your patients. And hopefully, you will be more mindful in considering the impact it has on other aspects of your patient's healthcare. And this hopefully will make you examine how you engage in and interact with your patients and their caregivers. And if you need more strategies on creating those winning partnership with your patients and families, then be sure to check out our other episodes that we've done. Episode number 41 is titled Managing Disagreements and Misalignment with Your Patients and Families. And episode 42, which is around quote unquote difficult patients, which I say there are no difficult patients. So make sure that you check out the links that I include in the show notes and check out these episodes. And if you want to go further, we even have another excellent episode on how the pediatric pain education is failing. That would be episode number 38. And this might help you understand and address and even avoid some of these common mistakes as well. So folks, I hope you found this episode useful. And like always, if you found it useful, please share it with someone else who may benefit from it as well. Also, please take a moment to review our podcast so that more listeners can benefit from it, as your reviews are the most effective way to get this in front of more people. So thank you, my listeners, for giving us the reviews. And thank you for all those who have already given us some amazing reviews. Finally, please submit any questions or topics that you would like to hear more about. In the meantime, I'm listening to you, my audience, and I'm continuing to bring you the information that you seek and desire. Next week, I will be answering a question that was put forth by another one of my listeners, and that is, why is it the right time to invest in gaining pediatric pain care skills right now? So, be sure to join me next week and hear the answer to this, because I truly do believe, for many reasons, that this is the time you must and you should be investing in getting some pain care expertise, more skills and tools to help you manage your patient's pain more efficiently. But until then, I say be safe, stay proactive. Bye now. Pediatric Pain Focus is a presentation of Proactive Pain Solutions, a company committed to transforming pediatric pain care through improved access, quality, and expertise. Did you know that there are only 4 accredited pediatric pain medicine training programs in the US? Meanwhile, there are 19 million children that suffer from chronic pain. This means the children's pain care is largely left in the hands of untrained healthcare professionals. This large gap in children's pain care leaves both the healthcare professionals as well as patients and families frustrated. Data clearly shows that untreated or poorly treated pain in children leads to a much higher incidence of refractory chronic pain that lasts into adulthood, much higher incidence of mental health diagnoses, and a massive societal burden. It also leads to poor job satisfaction and poor job security for healthcare professionals. Proactive Pain Solutions Physicians Academy is the answer to this major problem, eliminating that large gap through our comprehensive evidence-based virtual training program that's bolstered by live Q&A sessions, personalized mentorship, and leadership development. The limited time enrollment is now open and it offers a limited number of spots. So join our academy today and know what it's like to have the expertise at your fingertips while you enjoy the professional satisfaction and the job security that you deserve. Join us at www.proactivepainsolutions.com.